I'm aware that you are from medicine 1.
Good morning, everyone. Today, I would like to discuss about. I am aware that you are. This is regarding a patient, Miss B, a 20-year-old lady who is a first-year medical student from Bangalore, who has come with complaints of fever for 10 days and throat pain for 10 days. Coming to the history of present illness, her fever initially started as a high-grade fever, which was intermittent in nature and was associated with chills and rigors. She also had a throat pain, which was more while swallowing both solids and liquids. However, there was no history of any nose, there was no history of any headache or cough, there was no history of any vomiting or loose stools, there was no history of any abdominal pain, abdominal distension or jaundice, there was no history of any significant loss of weight or loss of appetite in the last 6 months. Coming to the past history, for the similar complaints, she has initially took a antibiotic amoxicillin for 3 days, and after that she has stopped it because of the gastric discomfort that she had. On clinical examination, the patient was conscious oriented. Her pulse rate was 104, which was regular, and BP was 110/70 with a respiratory rate of 18, and saturation was 99% at the room air. However, she was having a temperature of 100 degrees Fahrenheit, and on a clinical examination, she had bilateral cervical lymphadenopathy, which was symmetrical and around 2.2 centimeters. Tenderness was present, and the lymph nodes were firm with mobility present. However, there was no blanching rash or eschar present on generalized examination. On examination of the oral cavity, there was bilateral enlarged tonsils with follicles and white extract present on the bilateral tonsils. Other systemic examination was normal at the time of presentation. So, coming to the clinical syndrome, a 20-year-old young lady presenting with a fever with cervical lymphadenopathy with an enlarged tonsils.
Vaccination history.
We asked her, sir. We asked her. She said she is not. There was no parents that accompanied her. We asked the patient. She was not.
All the age-appropriate vaccination, all the things that we don't know.
She said in general it was given, but she was not sure.
She taken the boosters.
That I have asked her.
Okay, fever, X-rays on Johnson, cervical circulation.
As most of you have answered, our initial diagnosis was an acute follicular tonsillitis, and the second differential was infectious mononucleosis, and the third differential was diphtheria. Other differentials that we thought could be an acute undifferentiated febrile illness, probability of strep typhus, but that was at the least.
Somebody with enlarged tonsils and exudation.
That was the least of the diagnosis that we got.
Bobby, your differential should be based on the patient's history and clinical. You can't pull one diagnosis completely out. Why can't it be acute leukemia?
Because the lymph nodes are
Based on the patient's history and clinical.
coming to the basic investigations. The patient presented with a total counts of 15 lymphocytosis of 55%, and at the time of initial presentation, she had a elevated liver enzymes. Her SUOT was 414 and SCPT was 376. However, with the probability to rule out the other infectious causes, we took a blood culture and throat culture, which were both negative. We also thought of infectious mononucleosis, and we are sent for an antibody IgM test, which came positive for Epstein-Barr virus. For further course in the ward, on third day of admission in the ward, the patient had a sudden onset of right hypochondrial pain, and then on clinical examination, there was tenderness and palpation. So she was suspected to have a cholecystitis, and ultrasound abdomen was done, which showed features of acalculous cholecystitis with pericholecystic fluid, and that there was diffuse gallbladder thickening of around 6.1 mm. So the present diagnosis was infectious mononucleosis with hepatitis and acalculous cholecystitis. So why are we interested in this patient with the infectious mononucleosis with hepatitis and acalculous cholecystitis is because of the incidence of the hepatitis and the acalculous cholecystitis in such patients. Coming to the common presentation of infectious mononucleosis, they commonly have the which is fever, lymphadenopathy, and pharyngitis, which is present in about 90% of the patients, and which is usually seen in the young adults. Whereas in children who are less than 5 years of age, we may not see tonsillitis features, but they might have features of fever and lymphadenopathy. Whereas in adults, they may not have features of lymphadenopathy, but they may come with non-specific complaints like weakness, tiredness, and fatigue. Coming to the liver involvement in patients with infectious mononucleosis, more than 80% of the patients will be affected, their liver will be affected. However, the hepatitis usually will be a mild. The hepatitis that is present in infectious mononucleosis will be less than 5-fold of the normal levels. But this is a European Journal of Internal Medicine who presented a series of case reports where 47 patients who were diagnosed with infectious mononucleosis had elevated levels of liver enzymes, which is greater than 5-fold in number. And they found out that the liver enzymes were in peak during the second week, and they gradually come down after the third week. This is a recent case report in 2021 where a patient with infectious mononucleosis has presented in Syria. He's a 29-year-old male patient who was presented with no complaints of fever, but only tonsils, and he has went to a local physician. He was given, he was treated with ceftriaxone injection for 1 week. Even then, the fever didn't subside, and further, they suspected him of infectious mononucleosis, and he came positive for that. Even in this patient, the expected rise was only 205 and 185, but the patient showed increase, which is more than the expected. And in this patient, there is the prominent triad, which is supposed to be present, is not there, and there was only a subclinical hepatitis which was present. Coming to the other part, cholecystitis, which is acalculous cholecystitis that we had in our patient. This is again a journal published in 2017 where they observed a patients, around 14 female patients who were diagnosed with infectious mononucleosis, and they observed that all of them had elevated levels of AST and ALT liver enzymes, and all of them had presented with an acalculous cholecystitis, but only 3 of them had a classical triad of sore throat, pharyngitis, lymphadenopathy along with the fever. So this shows that there is a gradual shift in the trend that patients with infectious mononucleosis may not have like the prevalence of the hepatitis may not be less than 10% in young adults. It is gradually showing a trend, and slowly we might see an increase in the number of hepatitis patients presenting with infectious mononucleosis. Coming to the management of such patients, usually the management is supportive and generally self-limiting. We are supposed to give IV fluids and adequately hydrate them to prevent dehydration. Coming to our patient, we did only conservative management, and we provided her with NSAIDs and pain management, and repeated her LFT in the third week, which has come down to more than less than three-fold raise what she had in the beginning. Learning points from this patient is abnormalities of liver enzymes. Usually they occur in the first week with a peak in the second week, and they'll probably come normal after 3 weeks. And the possible occurrence of an A-calculus cholecystitis during an Epstein-Barr primary infection in a patient with infectious mononucleosis should be suspected. Thereby, we can avoid the overuse of antibiotics and unnecessary invasive procedures in such patients. Also, we should, as a physician, continuously monitoring the incidents and keeping a track of the case reports. We might slowly consider the increasing trend of subclinical hepatitis in such patients. Thank you.
Was an HIV serology done?
Yes, sir. It was negative, sir.
HIV RNA levels. Seroconverting illness would be very similar. Fever, lymphadenopathy, pancreatitis, lymphocytosis, and both viruses are transmitted to the same group of exposure. Did she develop a rash after the amoxicillin?
No, sir.
Do you also give antibiotics for this patient?
No, once the cultures have come negative and antibodies came positive, we stopped the antibiotics.
No further questions, and thank you.